Hey, welcome back to Not So Complicated, and it's day 5 clinical case discussion 5 for PLAB, USMLE, NBME, FMGE, AMC, and the case goes like this. A 58-year-old male presents to the emergency department with hematemesis and lightheadedness for 6 hours. He reports 3 episodes of vomiting bright red blood and a history of epigastric discomfort for weeks. His medical history includes alcohol use disorder, 20 years, 4 drinks per day, hypertension, and type 2 diabetes mellitus. He denies recent NSAID use or trauma. Medications include metformin and lisinopril. So basically, he is vomiting bright red blood, so which means it is a case of active bleeding, and also there is lightheadedness. It's because probably the hematemesis and vomiting is so severe that it is causing hypovolemia or hypovolemic shock. So NSAID or non-steroidal anti-inflammatory drugs use is not there, which reduces the chances of being this case peptic ulcer disease or like that. And so the vital signs are blood pressure 92 by 58 mmHg, which is hypotension, and probably because of the blood loss, and that is why it is a hypovolemic shock case. And heart rate is 112 beats per minute, which is tachycardiac. It is reflex tachycardiac for the compensation of hypovolemia. And respiratory rate 20 per min, normal. SpO2 95%, which is also normal, which means it is not hematemesis versus hemoptysis. So it means the respiratory system is intact, and temperature is 37 degrees Celsius. The physical exam revealed pallor, scleral icterus, spider angiomata on the chest, and a soft abdomen with mild epigastric tenderness. Rectal exam shows melena. So these symptoms right here: pallor, scleral icterus, spider angiomata on the chest. These are classic symptoms of liver cirrhosis. So basically, it might be the case of liver cirrhosis. Labs show that hemoglobin 8.5 gram per deciliter, which is far less than normal, and it may be because of the blood loss, obviously. And platelets 90,000 per microliter, which is far less. INR 1.5, which is increased, and AST under 20 units per liter, ALT 80 units per liter, total bilirubin 2.8 mg per deciliter, albumin at 2.9 gram per deciliter. Non-contrast CT abdomen shows a nodular liver and splenomegaly. So nodular liver and splenomegaly is due to liver cirrhosis, and liver cirrhosis complications like portal hypertension, and portal hypertension's complications like esophageal varices, maybe, and nasogastric lavage confirms active bleeding, which explains our hypovolemic shock. And what is the most likely diagnosis, and what is the next step in management? Let's debunk each of the options right here. Peptic ulcer disease, initiate IV pantoprazole. Mallory Wistier, perform urgent endoscopy. Esophageal varices, initiate IV octreotide. Gastric carcinoma, order biopsy via esophagogastroduodenoscopy. And erosive gastritis, initiate IV famotidine. Let's debunk each of the options. So first option is peptic ulcer disease, initiate IV pantoprazole. Let's debunk it. Peptic ulcer disease involves normally gastric or duodenal mucosal erosions, often from H. pylori, Helicobacter pylori infections. That is almost about 70% of duodenal ulcers, or NSAIDs in 20% cases. And epigastric discomfort, which is weeks, and hematemesis or melena fits in this case, but the patient lacks NSAID use and no H. pylori history is noted. So basically, peptic ulcer disease may not be present, but that is not an exclusion criteria for this. Scleral icterus, spider angiomata, low platelets 90,000 per microliter, INR 1.5, CT nodular liver, splenomegaly point to portal hypertension, not PUD. Varices cause 50 to 60% of bleeds in cirrhosis versus 20 to 30% for PUD. In the stats, it is highly likely that it is varices, but we cannot deny the fact that PUD also causes active bleeding in 20 to 30% of cases. The severity is maximum in this case because hemoglobin has dropped down to 8.5 gram per deciliter, and it is a hypertensive case, and it is an active bleeding case which is confirmed by lavage. But In PUD, it is often slower bleed, that is 100 to 500 ml, unlike it is brisk hemorrhage in our varices, like 500 to 2000 ml of blood volume loss. So it may be likely, but we have to check other options to fix it that it is or it is not the case in this clinical symptoms. Option B is Mallory Westier perform urgent endoscopy. So Mallory Westier typically results from forceful vomiting or retching in 80% of cases, often linked to alcohol binges, and they cause hematemesis, that is in 5 to 10% of upper GI bleeds. But this patient reports no retching, which means no forceful vomiting, and bleeding bright red. 3 episodes is severe. Hemoglobin 8.5 per deciliter, and BP 92 by 58 mmHg. So Mallory Westier normally doesn't have any severe bleeding in it. It has brisk, or it has minimal bleeding, so it cannot probably lead to hypovolemic shock. Melina suggests deeper bleeding, less typical for superficial tears, because Mallory Westier is superficial, and Melina suggests that even if the upper GI is bleeding, it is appearing as a symptom of melena, which is the blood in stool, which means the hemorrhage is extensive in GI tract. And also labs INR 1.5 platelets, and they reinforce coagulopathy obviously, and management, urgent endoscopy diagnosis, and treats tears, clipping 90% success rate in clipping, and often resolving spontaneously in 50% of cases. And for varices, endoscopy, which is bending, is eventual, but octreotide precedes to stabilize bleeding. We'll talk about that later, and it is very less likely. Next option is esophageal varices, initiate IV octreotide. Okay, esophageal varices are dilated veins, especially left gastric vein, and often resulting from portal hypertension, and portal hypertension often results from liver cirrhosis, and liver cirrhosis is due to chronic alcohol use in most of the cases. And in our case, there is a habit of alcoholic use disorder, like 20 years and 40 gram per day ethanol suggests obviously alcoholic cirrhosis, which is also, in fact, 50% of US cirrhosis cases are due to alcoholic reasons. And sclerolicterus, spider angiomata, which is telangiectasis from hyperestrogenism, which is the hemorrhage in superficial blood vessels, and obviously nodular liver and splenomegaly in CT. There is thrombocytopenia from splenic sequestration, and elevated INR, impaired hepatic clotting factors, and high bilirubin cholestasis, obviously low albumin because of reduced synthesis due to non-functional or minimally functional liver, and AST by ALT ratio is increased, which denotes the alcoholic pattern. And there is hematemesis, and melena reflects significant upper GI bleeding, and this is highly likely to be the case of esophageal varices, because almost every symptoms in our patient is matching with the findings. And the next case we have is, next option is gastric carcinoma, or order biopsy via esophagogastroduodenoscopy. So gastric carcinoma or adenocarcinoma in 90% of cases may present with hematemesis, melena, or epigastric pain, but typically it also includes weight loss, early satiety, or palpable mass. Obviously, weight loss is the characteristic feature of malignancy, and there is early satiety because there must be the compression due to palpable mass in gastric carcinoma, and this patient lacks these symptoms, and CT shows no mass. Nodular liver and splenomegaly is there instead, and labs also reflect liver dysfunction and not malignancy. Management, biopsy by esophagogastroduodenoscopy confirms cancer, but is diagnostic and not therapeutic in acute bleeding. The mutations in gastric cancer usually happen in cell addition genes, CDH1 gene, cell motility and cytoskeleton genes, RHOA, receptor tyrosine kinases, PIK3CA, and other genes, SMAD4, MUC6, W anti-signaling pathway APC, and CTNINB, 1 and chromatin remodeling ARID 1A, genome integrity TP53. This is a very high yield thing in the gastric cancer mutation profiles, so you can probably note it down. And the last option that we have is erosive gastritis or acute gastritis and initiate IV famotidine. So let's debunk this. Erosive gastritis causes superficial mucosal bleeding, and hematemesis is massive, bright red, hemoglobin 8.5 gram per deciliter. Melena suggests deeper bleeding, so it is not a case of acute gastritis because of this sole reason. And unlike gastritis, typical coffee ground emesis, in 50 to 70% cases we have coffee ground emesis, and CT nodular liver further excludes diffuse gastric pathology. And if it was a case of erosive gastritis, we should have managed this case via IV famotidine S2 blocker, 20 mg q 12-hour, reduces acid, but it is less effective than PPIs, which is pantoprazole, omeprazole, esomeprazole for bleeding gastritis, 80% versus 90% control. So this is a very highly unlikely case. But of note, the reason for acute gastritis, that is the very common symptoms in OPD, is due to that there are two balancing factors in this case. There are normal factors, and in normal cases there are damaging factors like gastric acidity and peptic enzymes, right? And there are defensive forces like surface mucus secretion, bicarbonate secretion into mucus, mucosal blood flow, apical surface membrane transport, epithelial regenerative capacity, elaboration of prostaglandins. These are the defensive factors to counteract with those damaging forces. But if the injury counterbalances the defensive forces or overrides the defensive forces, then the peptic ulceration begins, and the cytology is like necrotic debris, non-specific inflammatory cells are there, granulation tissue and fibrosis we can see in a microscopy. So diagnosis basically in this case is esophageal varices, and you can also comment how did you diagnose or what point led you to diagnose esophageal varices, and any special request on that you can comment that. So basically the mechanism of esophageal varices is that chronic alcoholic consumption caused alcoholic cirrhosis, and the hepatocyte damage caused fibrosis, which increased portal vein pressure greater than 10 mmHg, and the collateral veins formed to bypass the liver and dilating under high pressure, and those dilated blood vessels then ruptured, causing massive bleeding, 20 to 30% mortality per episode. And it is seen as hematemesis, bright red, high volume, and melena, digested blood. So hematemesis is bright red because it is a fresh blood, and melena is digested blood, so it is dark brown in color. And obviously coagulopathy INR is 1.5, low platelets from hypersplenism exacerbates hemorrhage. And the contributing factors in this mechanism is that portal hypertension, splenomegaly, thrombocytopenia, hypoalbuminemia, which causes the edema risk, and hyperbilirubinemia, which is due to cholestasis, confirm advanced cirrhosis in child POF or child target POF score, which we will talk about in later slides. And spider angiomata and icterus reflect hyperestrogenism and impaired bilirubin metabolism. So the clinical features of esophageal varices are pallor, scleral icterus. We have talked about it a lot in earlier slides, and also in labs hemoglobin drops, hypersplenism occurs, INR 1.5. We have talked about all of this. And the MELD score means model for end stage liver disease score. We do that score for estimating the mortality rate, and we have these slides attached. We have these photos attached in this slide. In our right side we can see the child POF score, which there are many factors that to be considered, that is total bilirubin, serum albumin, PTINR, ascites, hepatic encephalopathy, and each of that is assigned the points as per their severity, and then the total points are classified into class A, class B, class C, which then gives us the idea of 1 year survival rate. And also model for end stage liver disease score is also similar. So there is another slide in here the pathophysiology of that liver cirrhosis caused portal vein. There is reflux of blood, and it causes splenomegaly due to increased overload, and also gastric vein, left gastric vein, to cause the esophageal varices. And there are portal hypertension cases. The portal hypertension causes esophageal varices, caput medusa, which is seen in the umbilicus region, and hemorrhoids, marked ascites. They typically appear in portosystemic sounds regions like hemorrhoids and caput medusa in umbilical region, and also portosystemic portocavus system is in our left gastric vein and portal vein kind of thing, and arteriovenous sounding. And there are mechanical obstruction to hypersplenism is appeared is moderate anemia, neutropenia, thrombocytopenia, of course liver failure are also the sign of this. And the diagnosis criteria here is that the variceal bleeding requires upper GI bleeding, hematemesis, and portal hypertension evidence, and cirrhosis signs. Endoscopy confirms varices, but clinical or labs suffice initially, right? So basically the grading of esophageal varices in our photo is that grade 1, grade 2, grade 3, grade 4, but it can also be graded as 0, 1, 2, and 3. It is similar. The 0 is no varices, that varices run straight, then varices show beaded appearance, then varices run in oblique course and are tortuous with tumor-like appearance. The management of esophageal varices is via IV octreotide. Octreotide is a somatostatin analog, and it decreases the splanchnic blood flow and thus reducing the portal pressure. The dose of IV octreotide is 50 mcg IV bolus, then 50 to 100 mcg per hour infusion in 3 to 5 days. And also the rationale for using this is that it stabilizes bleeding before endoscopy. The endoscopy is done for band ligation in 80 to 90% success rate. Prioritize it over. That means we have to prioritize octreotide over vasopressin because the vasopressin has arrhythmia risk and somatostatin is less studied. And hypertension implies fluids, which means we have to give the fluid or IV saline 1 to 2 liter target is mean arterial pressure should be maintained above greater than 65 mmHg, and packed RBCs should be given 2 to 3 units also. And antibiotic ceftriaxone 1 gram IV daily for 7 days prevents bacterial infections obviously. And coagulopathy, if it is severe, that is INR 1.5 or mild, then we have to give fresh frozen plasma or vitamin K 10 mg IV if it is severe. The partial thromboplastin time PTT in normal range is 25 to 37 seconds, and prothrombin time is 9.4 to 12.5 seconds, INR of 0.1 to 1.1. And if the case is not managed in these states, then we have to do another 2 procedures. The first procedure here in the left slide is of the balloon tamponade. We have to use the balloon tamponade, and the tube here is Blackmore tube, or we can also use the Minnesota tube to use as the gastric balloon, which inflates in our fundus region. And this is one way to do the management. And the slide right here in our right side is of TIPS procedure, that is transjugular intrahepatic portosystemic shunting system. We have to do that we have to insert a metallic stent from jugular vein and then connect a branch of portal vein to a branch of the hepatic vein, so that the portal vein flows into the liver and hepatic veins flow out of the liver, not causing any congestion of blood. That is the another way we have to do. And if the workup doesn't work like that, in both of these cases we have to go for surgical shunting or liver transplantation. The prognosis of liver or esophageal varices is that acute variceal bleeding carries 20 to 30% mortality if it is almost for 6 weeks, and it should be controlled with octreotide or endoscopy. If it is controlled, it prevents early death in 70 to 90% of cases, and if there is rebleeding risk in 30 to 40% cases within 1 year, which requires beta blockers or TIPS procedure as we talked earlier. And cirrhosis severity, child POF B by C predicts worse outcomes, 40% is 1 year mortality. So there is also the indications and contraindications of liver transplantation. The indications are cirrhosis in all causes and intrahepatic malignancy, acute liver failure, Metabolic disease and contraindications are extrahepatic malignancy, active infection, active substance abuse, cholangiocarcinoma, non-hepatic comorbidity. The cirrhosis of liver presents with these Waldmann's symptoms like here, like jaundice, yellow skin and eyes, encephalopathy causing confusion, spiroangioma, and lack of body hair, muscle wasting, widened blood vessels, ascites, fluid build up, the red palms or palmar erythema that happens in cirrhosis of the liver. So that is all for today. Subscribe for our next case study, and drop comment if you have any special request or for any system to be covered up. Thank you.